with today with Tata Memorial Hospital, ACTREC, Rajiv Gandhi International Center. The Columbia Global is one of 11 centers which Columbia has across the world, and we're honored to partner with Dr. Anil Rastagi, who heads our Herbert Irving Cancer Care Center in New York. This is an interdisciplinary center, and Anil himself is one of the leading enterologists in the field of oncology. And I will now hand it over to Anil to take over.
Thank you, Rachna and Pooja. This is part of our series of collaborative webinars between Tata Memorial Center and its components, Rajiv Gandhi Cancer Center, and our cancer center at Columbia University. Our inaugural webinar was in December on breast cancer, and today's focus will be on head and neck cancer, so common in the world, so common and prevalent in India. And we will really have great speakers, 4 in total, who will be speaking about various aspects of current therapy and a preview of the future as well. And we hope this type of webinar spawns collaborations between the 3 institutes. So we'll be starting off on session 1 on treatment frontlines by Dr. Sudhir Nair, Chief of Neuro-Oncology at TMC, followed by Dr. Sinha, Radiation Oncology at TMC, who'll be speaking on radiotherapy. Dr. Lukman Dad at here in Radiation Oncology at Columbia University, who'll be speaking about the role of modern radiation therapy and precision oncology in head and neck cancer. Session 2 will be by Dr. Dwan, who's Director of Surgical Oncology at Rajiv Gandhi, on palliative care in head and neck cancer. And then we will entertain questions from the audience, and I'll moderate that for our 4 speakers. So I'll turn it over to you, Dr. Nair, as our first speaker. Thank you to you and all the speakers.
Thank you. Good morning and good evening for all of the viewers. Thank you, Columbia University, Dr. Rastagi, for inviting me to this prestigious webinar. Let me share this thing. Okay. Hopefully my screen should be visible?
Yes, we can see it. Thank you.
Thank you. So the topic assigned to me is the surgical aspects for managing head and neck squamous carcinoma with a focus on locally advanced oral cancers. Head and neck cancer burden in India, as you know, it's one of the largest cancer. We have a heavy burden of head and neck cancers, especially oral cancers, leading cancer in Indian men, highest burden of oral cavity cancers in the world, and about 60% are locally advanced at the time of presentation. And so we face many challenges. They come in late presentation, patients with very poor socioeconomic or varying socioeconomic disparities, and a lot of times they have limited access to specialized centers in different parts of the country. So a lot of times they come to hospitals like Tata Hospital for getting the treatment. And now, locally advanced head and neck cancers, if you see the picture on the right side, you can see they belong to with nodal metastasis. Stage 3 onwards, we call them advanced oral cancers. And very advanced is stage 4A cancers, which include T4A, where bone or skin is involved, primary site, or there are multiple nodes. And T4B, when there is involvement of the masticator space or carotid or skull base. So these are some of the classifications. So basically, we'll be looking how we manage T4 and T4A and T4B cancers and what are the differences. So they are the advanced oral cancers. So my focus will be oral cancer. So important aspect here is the staging. As you see, the staging should always clinically as well as complemented by sufficient radiological staging, either CET, MRI, or a PET CT. in India, we don't routinely do PET-CT unless there are multiple nodal burden, significant nodal burden, or a patient come back with a disease recurrence or second primary after the initial primary treatment. So generally for buccal mucosa cancers, we generally use contrast enhanced CCT, and in case of a tongue cancers, we use MRI scans. But in case we need PET-CT like multiple nodes or contralateral nodes or lower level loads, level 4, level 5 nodes, such situations, we may do a PET-CT. So that is basic workup. Biopsy is often, of course, we have to do it and confirm the biopsy. And and always these cancers, especially advanced cancers, should be complemented by a examination and anesthesia. Because sometimes in office, you may not be able to completely examine the oral cavity. Patient may be unable to open the mouth properly, and or they may have severe pain. So we may have to complement our examination by an examination and anesthesia, especially for advanced tongue cancers. So they require multimodality treatment, surgery, radiation, chemotherapy. The order will be initially surgery feasible, and then followed by radiation and chemotherapy, depending upon the final histopathology report. The anatomical extent of the disease dictates resectability. Unresectable disease, I have mentioned, skull base involvement, especially pterygoid plates. When we are not sure about getting a clear tumor-free margin, they are the unresectable diseases. Carotid artery encasement, vertebral invasion, and sometimes very poor performance status. Complex surgeries, patient may not withstand a complex surgery. Now, resectable locally advanced oral cancers, the curative surgery is possible with acceptable morbidity. It is done. And there are situations called borderline resectable. So where the patient may be clinically, radiologically resectable, there can be a high risk of positive large disease burden or disease going up to the skull base or very close to the high infratemporal fossa. So such cases, it may be a borderline resectable where a pure preoperative judgment may be difficult. Now, what are the principles of surgery? So I already mentioned a proper staging before surgical planning, a good clinical examination and proper clinical staging, which include examination of anesthesia as well as radiological imaging, examination of then a multidisciplinary tumor board discussion, achieve, then the surgeon should be make sure that you should be able to achieve a free margin all around at least 5 millimeter and a segmental. Now, the question of what type of resections to be done, whether the extent of the resection, whether it is segmental mandibulectomy, marginal mandibulectomy, and all those features have to be decided preoperatively. Then, during surgery or after surgery, the proper orientation of the specimen is very important because the pathologist have to clearly mention about the margins as well as extent of the disease. So these are a couple of things we need to do. So surgical strategies in locally advanced oral cancers. So in case of early stage cancers, there are controversies regarding where to go with wide excision or compartmental excision. In a case of advanced oral cancers, that is not there because most of them, they often result in compartmental excision, remove the complete excision of the tumor. Then there is elective neck dissection. We know that early stage, there were debates, often that is also settled now. But all these cases, we have to do an elective neck dissection if there is N0. And if it is N plus, we may go ahead with a moderate radical neck dissection, modified radical neck dissection. But sometimes the controversies exist regarding selective neck dissections versus MRND. Most of the time, we do MRND, especially with our multiple nodes or nodes in lower levels. For single level 1 node or level 1A nodes, probably an SND can be also equally suffice these cases. Now, regarding the surgical resection of oral cancers, you see this picture I adopted from Ansarin's paper, Head and Neck, published in 18. So the different classifications of here, and here I am mainly focusing on advanced tongue cancers, which include a type 4A glossectomy or type 5 glossectomy. A type 5 glossectomy is almost a complete or total glossectomy, and type 4A glossectomy is anterior to third glossectomy. Type 4B glossectomy is a near total glossectomy, where part of the base of tongue is also excised along with the glossectomy. So the picture is very self-explanatory and depends upon the extent of the disease. So in this, these are the primary excision. Along with that, when the lesion is reaching or crossing the midline, you need to do bilateral neck dissections. If it is a very lateralized lesion, we consider unilateral neck, ipsilateral neck dissection. But when the lesion reaching the midline or crossing the midline, it is better to do a bilateral neck dissection. Now, regarding the T4B buccal mucosa cancers, see the NCCN classified T4B altogether as an unresectable category. But in India and other Southeast Asian countries, we have a lot of buccal mucosa cancers because of the chewing habits of the local population. We get a lot of buccal mucosa cancers, and especially in very young stage, patients comes to us. And what we observed that some of these cancers are resectable without much morbidity to the patients. So even T4B are, as I previously mentioned, they include involvement of the infratemporal fossa or involvement of the any of the masticator muscles of the mastication, or that like pterygoids, medial pterygoids, or even extending up to the lateral pterygoids. So traditionally deemed unresectable, they are we have current surgical advancements, extended resection, including a compartmental excision of the infratemporal fossa muscles. And sometimes these are sometimes very higher, going higher up, they may be considered as a borderline resectable cancer. So we may give neoadjuvant chemotherapy so that the disease is shrunken, so that we can remove the infratemporal fossa contents without much surgical difficulty. So this is an important aspect of T4B diseases. So this is a picture which is showing a compartment resection for T4B buccal cancers. As you see, all the pterygoid muscles, the masseter, if there is a masseteric involvement, the entire masseter is removed from the zygoma. Cutting end is that the medial pterygoid, lateral pterygoid, they are removed in toto along with the pterygoid plates. So a lot of series from India have been published regarding the successful completion. And in our own paper, the previous paper, we have seen that their survival, if you get a tumor-free margin in them, they are equivalent to T4A cancers. The outcomes are equivalent to. So the important thing is to we get a tumor-free margin. So a proper radiological evaluation preoperatively and the proper surgical techniques are important. Now, so that is the paper which shows that compartmental resection for ITF clearance. What we can see is in T4B, when there is an infra-notch disease and is not negative, we found 29 months as survival. But when it comes not positive, there is a reduction in the survival. But in a supra-notch disease, if still it undergoes surgery, at least we get almost 20 months survival. Whereas if it is unresectable disease, the survival is very poor. Of course, this was published in 2018. Now we have newer neoadjuvant chemotherapy regimens have come in using immunotherapy and other things. So again, this can change with the more availability of immunotherapy regimens. But of course, countries like India, because of the costly regimens, may not be always feasible, and surgery is still the easier and best way of managing these cancers. Now, reconstruction strategies is very important. We have to restore the form, function, and aesthetics. Free flaps, we have a range of options. Free flaps, obviously a very good choice, easy to reconstruct, but technical complications are there. You need expertise and a dedicated plastic surgery team most often to do that. But pedicle flaps was workhorse flaps a long time. Nowadays, we do less and less amount of PMMCs, but still PMMCs still serve whenever a flap failure happens, multiple flap failures, or in case of salvage resection where the plastic surgery team may be reluctant to do a free flap, such situations. And with local flaps, we use a lot of submental artery island flap, nasolabial flaps for reconstruction of some of the cases, but these local flaps may not be much suitable in very high defects. So obvious choice in most of these cases will be free flaps. So the quality of life, it is multidisciplinary rehab, speech and swallowing therapy, counseling and evaluation is essential before starting the treatment and after completion of the surgical treatment, because these patients need long-term support, speech and swallow evaluation, they have aspiration and other problems. So therefore, it is very important. So either the head and neck treating surgeon should be efficient in managing this, or we need a specialist dedicated speech language pathologist in the hospital, especially in case patients undergoing large defects, to glossectomies, near total or total glossectomies. And then in our population, especially, we see a lot of trismus cases because of oral submucous fibrosis. So that is very important, and the management of this thing is very important. And patient survivorship programs are very important. These patients have often changes in their face, their appearance, and social reintegration programs and psychological counseling is essential. So in conclusion, surgery remains the mainstay for locally advanced oral cancers when feasible. Multidisciplinary planning ensures optimal oncological and functional outcomes. There should be need for strengthening rehabilitation and survivorship programs. So a successful surgery is not just about survival, but about a meaningful life after treatment. Thank you.
Thank you, Dr. Nair, for a great overview and update. We'll now go to Dr. Sinha, radiation oncology at Tata Memorial, who will be speaking about role of radiotherapy in head and neck cancer treatment. Dr. Sinha?
Yeah, thanks a lot, Dr. Rizki. So is my screen visible? One second. Is my screen visible?
Yes, it is now. Thank you.
Thanks a lot to Dr. Rizki. So good morning and good evening to everyone wherever we are in the world. And I'll be talking about adjuvant therapy. Primarily, I will restrict myself to oral cavity cancers. So Dr. Nair already alluded to this. If you look at India and compare it with USA, the incidence of oral cavity cancers is almost double that of USA if you go by the 8 standardized rate. But the proportionate mortality shows a difference. In India, approximately 50 to 60% mortality is there, whereas if you look at the data from United States, and only 10% or so. And this is primarily due to the number of advanced cancers that we see in India. This was already discussed. Surgical resection with negative margin remains the mainstay for treatment for oral cavity cancers. This is a large NCDB database analysis, 7,000 patients comparing surgery plus support versus definitive CRT, and across stages and across primary sites, surgery plus postoperative radiotherapy seems to do better than chemoradiation. So then why do we need adjuvant treatment in oral cancers? Approximately 70 to 85% of recurrence in oral cavity cancers are still locoregional, and the most common histology, that is squamous carcinomas, are radiosensitive and chemosensitive. If you look at salvage rates for locoregional recurrences, they are extremely poor. It is approximately only 10% of these patients that we can salvage with curative intent. This is our data, and it is associated with high morbidity and poor quality of life. And outcomes with salvage are also extremely poor. The 2-year overall survival ranges between 20 to 30% only. So it is essential to give the best possible first treatment to these patients. And that is why adjuvant treatment is essential in advanced oral cancers as well as some early oral cancers. So if we talk about early oral cancers first, they are usually considered as stage 1 and 2, and certain low volume stage 3 cancers are also clubbed together. So the 5-year OS, if you look at various reports from across India, it usually ranges between 65 to 85%, and around 15 to 40% are aggressive tumors, and they require adjuvant therapy among these stage 1 to tumors. Now, as of now, we use various histopathological factors to guide adjuvant therapy. There has been a recent focus on tailoring indications for adjuvant treatment in early cancers. There has been a focus on reducing doses to both the involved sites as well as the elective sites. There has been a focus on reducing volumes, and altered fractionations are also being tried. There has been a recent recognition that probably buccoalveolar and tongue cancers, which are usually clubbed together when we consider the staging as per the AJCC 8th edition, can behave differently, with tongue cancers having an aggressive natural history. And if you look at the principles of radiotherapy, elective nodal irradiation is usually considered despite surgical dissection revealing a PN0 or PN1 status, and we'll come to this later on. But as of now, if you look at early oral cancers and we are deciding on adjuvant therapy, we have high risk factor, most important of which is positive margins. So if a patient has positive resection margins, most of us will like to consider at least adjuvant therapy, radiotherapy in most of the early oral cancer cases. Of course, there are exceptions, and there are certain intermediate risk factors. They are mainly on pathology. They include perineural invasion, lymphovascular emboli, worse pattern of invasion, poor differentiation, close margins. So based on these, we usually look at one or two or multiple risk factors, and then we decide whether our patient with early oral cancer mandates adjuvant radiotherapy. So if we look at what are the ongoing research in early oral cancers, we have some studies studying the de-intensifying volume, that is reducing elective RT doses. We have RT versus observation in early oral cancer. There is a one randomized trial, that is the ARREST trial. We saw the report of the HIPOT in 2023, which is modest hyperfractionation in the adjuvant setting. We have dose reduction trials also in the adjuvant setting in early oral cancers, and we are also gradually hearing about proton hypofractionation trials, particularly from the Mayo Clinic group. So at ACTREC and Tata Memorial Center, we have a couple of multicentric trials going in the adjuvant setting for early oral cancers. We have the APRON trial, which is looking to de-escalate the volumes. So we are omitting the radiotherapy. The elective RT volumes are being omitted for PN0 and PN1 neck. So this trial is already accruing. This is a multicentric trial. We also have the ARREST trial multicentric, again headed by Dr. Sudhir Nair. This accrual is actually completed for this multicentric trial. ACTREC was one of the centers for this. This is testing RT versus observation for patients with oral cancers with depth of invasion between 5 millimeter, depth of invasion between 5 to 10 millimeter. So the data is maturing for this trial, and we will soon hear about the results of this trial. So when we look at locally advanced oral cancers, they are usually considered as the stage 3 and stage 4 tumors. Now, although randomized evidence is a bit lacking in this domain, but there are multiple retrospective and prospective observational studies which shows that port should be recommended for advanced oral cancers. This is the famous RPA analysis from MD Anderson group published in 2005, which showed that advanced oral cancers do benefit from post-operative radiotherapy. And this was the pooled analysis, famous pooled analysis by Bernier and Cooper of the ERTC and RTOG trials, which showed that patients who have margins positive and extracapsular extension benefit from addition of concurrent chemotherapy to radiotherapy in the adjuvant setting after resection. Of course, this analysis was not restricted only to oral cancers, but we largely follow this. Recently, we have started looking at which patients beyond EC and margin positive can benefit from addition of systemic therapy. And of course, there are multiple reports, although most of them are retrospective. The most common candidate for intensification of adjuvant treatment is the multiple node positive cohort. More than 4 or 5 nodes positive without any becomes an indication for chemoradiation in some centers as per institutional practice, even in India. Then patients with multiple risk factors like PNI, LVE, poor differentiation also are sometimes considered for chemoradiation in the adjuvant setting. So we have our share of experience with this. This is perhaps the largest randomized trial restricted only to oral cavity cancer. This was a phase 3 randomized control trial conducted between 2005 and 2015, enrolling 900 patients, testing standard adjuvant RT versus CT RT versus accelerated RT, that is 6-day RT in locally advanced oral cavity cancers. And although the trial failed to meet its primary endpoint of overall survival in favor of any of the altered fractionation or the chemoradiation arms, but there was definitely a signal where patients with multiple risk factors such as T3, T4 disease and N+ disease were benefiting from either addition of concurrent chemotherapy or the 6-day RT. And of course, we recently saw the results of the RTOG0920 trial again, and this tested adding of cetuximab to standard RT versus RT alone in again a cohort of advanced head and neck cancers, not again primarily restricted to oral cancers. And while the trial again failed to meet its primary endpoint of overall survival, there was a signal of DFS benefit in a cohort of patients. And on subgroup analysis, we saw that again, patients with multiple risk factors may perhaps benefit with addition of systemic therapy to radiotherapy in locally advanced head and neck cancers post-surgical excision. And of course, we again heard about this immunotherapy has changed the landscape in variety of cancers, and we are beginning to hear more about it, and even in head and neck cancers in the curative setting. This is the result of the Keynote 689 study. This was recently presented in the AACR annual meeting, and this is testing perioperative immunotherapy, which means 2 cycles before surgery and 15 cycles after surgery given along with radiotherapy. And there was approximately 11% benefit in the 3 years event-free survival. We, of course, await the final results of this trial. So what is the future in advanced oral cancers? The ECOG Acrine 3132 trial is actually looking at TP53 sequencing as a method to identify patients who benefit from addition of systemic therapy. We have the NRG RTOG 1216 trial, which is looking at addition of RT plus docetaxel plus targeted therapy, that is cetuximab, as well as immunotherapy in the post-operative setting. And we have also the NRG HN009 trial, which actually is not restricted to the adjuvant setting, but still we hope that it will clearly answer the question of weekly versus 3-weekly cisplatin when being added to radiotherapy. So very quickly, we know that radiotherapy should be started at an optimal time after surgery. We are very, very particular at Tata about this. We look to start patients within 6 weeks of surgery, and unless unavoidable due to some surgical complications. This is again a large NCDB analysis which show of around 40,000 patients, which shows that if RT started beyond 6 weeks, there is almost a 5 to 9% decrease in local control. We usually use IMRT or VMAT for our adjuvant oral cavity patients. Sometimes we also do protons. Our dose fractionation is 60 gray, 30 fractions. Sometimes we do follow a modest hypofractionation of 50 gray in 20 fractions. Our preferred concurrent chemotherapy regimen is weekly cisplatin 40 milligram per meter square, again in platinum fit patients. And as I already said that we really want to start our patients within 6 weeks after surgery. So to conclude, oral cavity cancers, adjuvant RT plus minus chemotherapy or systemic therapy is the cornerstone of management of these cancers, especially in countries like India, where we see a lot of advanced cases. And while there are defined indications from studies done in previously, we further have to define and individualize these indications. Although I did not specifically address this issue, toxicity and quality of life should always be considered when we are considering an improvement in survival with addition of a modality. And multidisciplinary specialized care, including rehabilitation and rehabilitations, are essential for optimal outcomes. And in the future, we will hear about immunotherapy, targeted therapy profiling, and proton therapy, even in the adjuvant setting for oral cancers. So with this, I end my talk, and I also welcome you to the sprawling ACTREC campus in Navi Mumbai. Whenever you guys feel suitable, please do visit us. Thank you.
Thank you so much, Dr. Sinha. A great talk again, and a great overview and update. We'll now turn our attention to Dr. Dad here at Columbia University in our Cancer Center, as mentioned before, and he'll give a Columbia and U.S. perspective on modern radiation therapy in head, neck, and oral cancers. Dr. Dad?
Thank you, Dr. Rusky. I appreciate everyone for hopping online to take a listen to us this morning in the States and evening in India. So I joined Columbia in 2023, and I help co-direct the head and neck cancer group at Columbia. I wanted to share a little bit about myself before we dive into the meat of my talk. Is mostly on clinical operations and practice building, which I think we have lessons to learn going both ways. My parents immigrated from a small village in Pakistan in the late 70s for aspiring for a better life for their family. I was blessed to be born in Maryland. I attended college and medical school in Boston at Boston University. I did my residency in radiation oncology at Roswell Park. And then I was in private practice for over 10 years in closer to home in Maryland. And 2 years ago, I jumped back into academia, working alongside my medical school mentor, Dr. Lisa Kachnick. So when I was a resident, I had the passion, and I'm hoping that there are some trainees on the call today. My passion as when I was studying in college and through medical school and during residency was in global health. I helped start the my specialty society's first trainee initiative called the Aero Astro Global Health Scholars Program, where we built funding support for 3 trainees to study, to conduct research and clinical work in a low middle income country. And so the hope was that that would build lifelong learning and build relationships so over time we can help close the gap, as our previous speakers have alluded to, and you're very much familiar with. The bulk of the burden of cancer in the world is in places without standard of care, meaning limited access to modality like radiation. So at Columbia, we have 14 clinical faculty, each dedicated to a disease site. My focus is in head and neck cancer and sarcoma. We also have satellite clinics in Westchester, Hudson Valley, the Bronx, VA. This past spring, we launched a partnership with Procure Proton Center, which is located in New Jersey. And the head and neck team here on this slide, you can see our entire interdisciplinary team at Columbia. We have 3 head and neck surgeons, and then I think I really love working with all of these colleagues of ours who are exceptional. And we meet on a weekly basis for tumor board, and we also meet weekly. I meet with the oncology rehab and members from ENT, medical oncology in a huddle, because as you're familiar with, coordinating and getting our patients through treatment can be quite challenging. I wanted to give you all a sense of our patient population. At first glance, I think you may see Washington Heights or New York City worlds away from mega city like Mumbai and New Delhi, but we do have many similarities in the people that we're serving. At Columbia is housed in Washington Heights. It's a community predominantly of Black and Latino population, lower socioeconomic, with similar struggles as many who live in urban areas of India. So although oral cancer is probably in the top 3 in incidence in India, and not as common in the United States as we saw in other slides earlier. But in Washington Heights, we do see a fair number of patients with social factors like alcohol and tobacco abuse and lack of access, and they present with locally advanced disease of the oral cavity and oropharynx. So my hope is, with these similarities and the people that we serve, that there may be ways that we can optimize our care and find solutions that may be aligned for both populations. And I think that's what's exciting about a potential collaboration with all of you experts in Mumbai, Delhi, and with us in New York. The one area that I think is of importance, particularly with some of our work that we've been doing in collaboration with the Center for Radiological Research, is in figuring out optimal fractionation schemes for patients with locally advanced disease, but who may have factors both in their protoplasm in terms of ability to tolerate standard of care, 6 to 7 weeks of treatment, plus or minus chemotherapy. So there may be more shortened or abbreviated courses of radiation that may be suitable. Dr. Nair highlighted this, and I want to emphasize this as well. I think when our talk today is really a focus on oral cancer, locally advanced oral cancer, because both of our populations we serve, we face this daily. And I want our residents to remember the cornerstone is primary surgery and having a reconstruction, modern reconstruction availability at hand. The focus of surgery is for oncologic resection, margins, maintaining function, and achieving disease control. Total package time, Dr. Sinha commented on this, and I want to also remind everyone, we have very strong data from multiple centers that have shown that when the time from surgery to completion of radiation is more than 100 days, that impacts overall survival and local regional disease control. And in one of the studies by Gandhi from Henry Ford, they highlighted that issues like wound healing, insurance and socioeconomic, and comorbidities, sometimes you have patients with locally advanced oral cancer who also have a slew of other medical problems. But what's really critically important in this factor that impacts survival, often more than some of the modalities impact survival, like offering chemotherapy, has a single-digit translation of survival benefit. But if you can optimize medical comorbidities, socioeconomic and insurance status, and wound healing, all a part of what I would call oncology rehab, I think that may impact overall survival in a more dramatic way. So total package time is a very important factor. And, Tata Memorial is an extremely high volume. Your experts at Tata have the most experience in the world, and we have a lot of lessons to learn how you are able to achieve your outcomes in a way you're able to manage in a setting like that of India, and to be able to translate those challenges and really have success in managing locally advanced oral cancer, because we often struggle with that in our home here in New York City. Precision diagnostics, pathology, radiation medicine, those are all components of a robust head and neck cancer program. I think having expert head and neck surgical pathologists is absolutely critical, just as it is in radiation. When we think of precision in 2025 for head and neck, we're hoping in this year that we'll be launching our use of online adaptive radiation therapy with the Ovarian Ethos platform, which will allow us to accommodate for target changes and changes in patient anatomy in a more frequent basis. Predictive tools is an area of ongoing work. I think traditionally we've relied on mathematical modeling, like the linear quadratic equation and calculating biologic equivalent dosing. But there are other areas that our researchers at Columbia, led by Dr. David Brenner and Igor Shuryak and the Center for Radiological Research, that are looking for ways to combine mathematical modeling and also machine learning to factor in other factors like demographics, patient medical history, treatment package time, other factors that play a role in how much certain factors in a treatment can impact outcome. And finally, I think not to be forgotten, but hopefully Dr. Dwan will be speaking about this more, is patient survivorship, because survivorship begins at the time of diagnosis and their journey through their cancer, their rehabilitation, and making sure that we pay attention to patient-reported outcomes. I'm going to quickly go through the next few slides. I think that, not to belabor the point, but whenever and I know that Tata is going to be continually growing, especially your outpatient programs. It's important when you think of cornerstones of a high-functioning, multidisciplinary, disease-based team to have the strong leadership as you do. And we are led by Dr. Rusky, who's really has finger on the pulse of our teams at Columbia. Having dedicated care coordinators is absolutely pivotal. I think that it's easy for us to operate in silos or vacuums, but managing head and neck cancer is a very complex disease site. And patients require a lot of support from the time of diagnosis through their survivorship and follow-up. And having that care be coordinated, particularly with patient and nurse navigators, is critically important. What we have done at Columbia is transitioned some of our work mainly to the electronic medical record, particularly for our tumor boards, where we have the entire workflow set up within our EMR. And we also report our consensus from our tumor board cases that were discussed to appear in each patient's chart. And I think that has really led to a lot of efficiency and satisfaction with our staff. This work that we've done with implementation of interdisciplinary EMR integrated tumor board, one of our residents at Columbia submitted an abstract that was just accepted at ASTRO. So we're very proud of his work on that to help us continually improve our outcomes. Because what we think of as smaller things, actually, I do believe help us in managing that important factor, which is total package time, which involves under the umbrella of coordination of the patient's care. Now, this trial I wanted to raise, and I was hoping that when we have discussion at the end, that we can talk about some of the effort in thinking of ways to alter fractionation to adjust for some of these factors that can limit our patients from being able to complete treatment when you have a locally advanced disease and a very relatively ill patient with not a lot of support. We have to think of ways to deliver a dose that can offer meaningful disease control, but that can be completed in a matter of time that is reasonable for the patient and for the entire team and institution. So the HYPNO trial explored what I would call moderate hypofractionation, 20 fractions to traditional 6 weeks of treatment. And I thought what was exciting about this trial was that it incorporated host sites in 12 centers, 10 low middle income countries from 4 continents, including India. And I'm sure many of you are familiar with the HYPNO trial. And it was presented in ASTRO in 2023, and it showed, despite us not having yet seen the publication, there's been a lot of excitement, I think, in places where we focus on delivering care to a more underserved population, that there's non-inferiority when you compare altered hypofractionation plus or minus weekly cisplatin to accelerated RT over a 6-week period. At Columbia, I mentioned Dr. Suryak earlier. He's been doing a lot of work in helping us better understand how we can combine mathematical modeling with machine learning. And then this is something that excites all of us at our institution on ways to take advantage of artificial intelligence and optimizing, tailoring the care, and also informing the patient in a more hopeful, accurate manner. Dr. Parikh is one of our head and neck surgeons. I'm highlighting him here because he's an example of a translational surgeon where he's taking some of his work at the bench and hoping it translates to the bedside where, for example, we know there is extreme tumor heterogeneity in head and neck cancer. And I think the vision is that we can translate some of the information we learn from sampling tumors on deciding on which treatments may be the best to offer a patient for optimal outcome. With that, I'm going to be concluding now, and I think that I know that I didn't give you very much of a granular conversation about radiation. As much as I want to share with you, this is a tremendous opportunity for Columbia to exchange knowledge and expertise with one of a few of the world's biggest centers, Tata Memorial and Rajiv Gandhi Cancer Institute in India. My hope is, as I did when I was a resident, to help foster our specialties global health scholars program, is that when we have medical students and residents who may have an interest in learning from your expertise and your high volume, that this can be an opportunity for exchange for those students and trainees. Also, there are opportunities to collaborate on setting up symposia, clinical trials, to help with our ongoing work in data and machine learning, developing patient education tools that are better serving the population that we see each day, and hopefully in helping you optimize your care delivery, similar to what we've done with our tumor boards. And this may hopefully lead to more collaboration amongst our institutions. So with that, I want to thank all of you. You have my email, and you can find me on LinkedIn or Instagram. And we're always willing to be partners for you to reach a better place for all of us. Thank you so much.
Thank you, Dr. Dad, for that overview and a holistic view emphasizing sort of not only interdisciplinary care, but all aspects of patient care, which really leads us to our next and final talk by Dr. Dwan on palliative care and head and neck cancer. Dr. Dwan?
Good morning, good evening. You see, last month I was asked to talk about surgery in head and neck cancer. I said, Dr. Nair is talking about surgery. Let me talk about when not to do surgery. So today I'm going to share my experience about palliative care in head and neck cancers. I'm working in Rajiv Gandhi Cancer Institute, but I also run a charitable palliative care center in the state of Uttarakhand in northern part of India, near Holy River Ganges. Palliative care, as you know, is a specialized medical care for people with life-limiting illness such as cancer. It focuses on care and not cure. It affirms life and regards death as a natural process. The goal of palliative care is to improve quality of life of both patients and caregivers. It is based on patients' needs rather than on prognosis. So question is, why palliative care in head and neck cancers? The data says globally, head and neck cancers constitute 9% of all cancers. In Asia, head and neck cancers constitute 12.3% of all cancers. And India, it is 18%. In Delhi, it is 19%. And in the state where I have the palliative care center, Uttarakhand, it is 23%. And in my hospice with the name of Ganga Prem Hospice, 26% of the patients are head and neck cancer patients. And why it is important to know about palliative care in head and neck cancer. You see, surgery is quite disfiguring with scars on face and inability to eat in public with drooling of saliva. Patient's speech, his food habits are altered. It is psychologically quite disturbing with a lot of social stigma, financial loss, and so on and so forth. So cancer impacts patient as well as family. For patient, there is a poor coping mechanism. depression, withdrawal from social support, fear of recurrence. There is actually fear of 6 Ds: discomfort, dependency, disfigurement, disability, disruption, and death. Family is also worried about abandonment by the other people of the patient. We as healthcare professionals are also stressed. Let us see what are the problems of these head and neck cancer patients. These could be disease-related, like pain, wounds, orocutaneous fistulas, maggots in wounds, satellite nodules, distant mets, and cachexia. Treatment-related problems could be xerostomia, vision problems, palatal defects, and some aesthetic issues. There could be emergencies in advanced cases, terminal patients. They could have stridor, vascular blowouts, and the terminal events could be bleeding, aspiration pneumonias, chest infections, and most horrifying aspect is patient visualizes his death when he sees himself in mirror. Here is the data from Mayo's Clinic, quite old publication from 1909 to 2001 of 93 patients, and which enumerates common symptoms in head and neck cancer patients: pain and bleeding in 14%. It is a long list, but at Ganga Prem Hospice, where I'm talking about in Uttarakhand area, symptoms at the time of admission in hospice are pain in 90% patients, wounds in 40% patients, cachexia in 65%, bleeding off and on in 12%. And I'll show you a few of the ghastly pictures. And these are real pictures from hospice. The severity of these symptoms, frequency, level of interference with activities, and the level of stress may vary from patient to patient. Patients' assessment of symptoms may vary from that of health professional. Clinicians tend to rate the severity of symptoms lower than patients. Symptom severity is a useful guide to treatment. When we assess pain in palliative care setting, we include social, psychological, spiritual components also, and call pain as total pain. See, in busy OPDs, we talk of only physical component of pain and prescribe medicines. We don't go into the details of other components. That is why we add antidepressants and sedatives in the cocktail of analgesia. Cancer pain, by and large, is a chronic pain persisting for more than 1 month. It lacks objective signs and has got negative effect on quality of life. When we talk of blocks for pain relief, these are most effective for abdominal and pelvic malignancies, but not so much effective for head and neck cancers. Glossopharyngeal nerve block is useful for referred pains from oropharyngeal cancer, hypopharyngeal cancer. But problems in head and neck blocks are changed anatomy, neoangiogenesis, poor efficacy in cancers due to necrosis in local areas. Blocks are good for neuralgias and benign conditions. These are general rules for giving analgesics: by the mouth, by the clock, by the letter. Everybody is familiar with it. For the individual, meaning correct dosage that relieves pain to an acceptable level. And attention to details means safeguarding against side effects. Analgesia stepladder approach usually sums up all. How do you escalate or titrate the dosage of analgesics? I will not discuss the guidelines for opioid use. There are some other symptoms which are very pertinent in head and neck cancer patients. These are mucositis, dysphagia, xerostomia, malnutrition, cachexia, fatigability. For mucositis, emphasis is on oral hygiene, and we use a magic mouthwash formula which contains xylocaine, diphenhydramine, and aluminum hydroxide. Some people even add antifungal and antibiotics. For xerostomia, we encourage lots of fluids and artificial saliva. And malnutrition may necessitate tube feeding, but rarely parenteral feeding. Remember one thing, that you can only salvage the salvageable even in end-of-life care. Salvage if you can improve the quality of life. Say tracheostomy can be done as life-saving procedure, but be careful about woody irradiated necks or transtumoral tracheostomy or fungating wounds in the lower neck. Don't venture. Vascular blowouts are usually preceded by warning bleeds, and nowadays we do more of embolization rather than open surgeries and do any vascular ligatures. Wound debridements may be required for osteoradionecrosis. There are other procedures like gastrostomy and esophageal dilatation in palliative settings. Palliative radiotherapy, palliative chemotherapy may improve the quality of life, may not improve survival. But my appeal to all the oncologists is, don't keep giving them chemotherapy or immunotherapy till the end. And my boss used to say, don't make the patients walk to the autopsy room. You should know when to stop treatment, and palliation is not an endless game. Few days back, a similar patient came to me for opinion. Carotids were exposed within tumor tissue. He had been operated, irradiated, now on chemoimmunotherapy with progressive disease. And he visited one of the vascular surgeons who said that I will operate you and put vascular graft. I said, no surgery, please. And I told the surgeon, let the patient do his own dying. In a nutshell, salvage the salvageable, and you should know when to stop treatment, curative or palliative. Knife is not the answer for all problems. And I will say that decisions are more important than incisions of surgery, precisions of radiotherapy, or solutions of chemotherapy. Our approach should be patient-centric, and we must communicate honestly with the family. We should discuss the risks and benefits of any treatment, especially at the end of life. We should keep reviewing the situation regularly, and non-beneficial treatment should be stopped. Communication is the key. We always talk of good quality of life, but rarely talk of good death. Good death means patient is pain-free with symptoms controlled, and patient is prepared to leave, and all his conflicts have been resolved. At the end, he is at a place of choice, surrounded by his own people. To summarize, terminally ill cancer patient should live well, he should leave well. Thank you.
Dr. Dwan, thank you so much for that inspirational talk. We very much appreciate it. I'd like to now open up the remaining time for questions or comments from those that have joined us on this Zoom meeting. If you wish to put your question or comment in the chat, perhaps I could start off with a couple of questions. Dr. Dwan, other end of the spectrum, prevention in India, how much progress has been made in that context about avoiding certain risk factors?
I think most important is awareness about cancer causation, and then of course clinical examination, means screening, these are far and few initiated by Tata Memorial Center and at Adyar, Chennai, and few of the southern part of India. I'm not aware of any screening campaign or screening program by Government of India emphasizing on early detection and cancer awareness. As an institution, we do it on an individual basis and do more of opportunistic screening rather than in an organized way.
I see. For everybody, if you could remind us of how therapy might be influenced by human papillomavirus infection. To that end, let me start with Dr. Nair and then Dr. Sinha and Dr. Dad and Dr. Dwan. Dr. Nair, again, HPV and its detection and influence on surgical therapy.
Yeah, so of course, I know it's a hot topic in US. Our experience in HPV cancers, we routinely do HPV evaluation for oropharyngeal cancers. So, not for oral cavity cancers because the incidence is almost extremely less. So we don't do HPV screening for oral cavity, but oropharyngeal cancers, Tata, we follow the P16 estimation, surrogate marker. Now, the problem in HPV, though people talk about de-escalation and other aspects, in our patient population, we are having intermediate risk factors mostly. Though even they are HPV positive, most of them are tobacco users also. They have so they are some sort of intermediate or high risk factor. So we may not be able to de-escalate even if you do it, HPV and them. But we still we do it for documentation, and some of the patient, I think Shwetab can update on that because in oropharyngeal cancers, predominantly they are managed by non-surgical methods, CRT or CTRT. So I think Dr. Shwetab can be do, but oral cavity we now do HPV screening.
Okay, good to know. Dr. Sinha, you had mentioned now in the future of immunotherapy. In these patients who are HPV positive, let's say oropharyngeal cancer, what is the role, what might be the role of immunotherapy going forward?
So at least I can give you the Indian perspective. First of all, our HPV positivity incidence is nearly only 10 to 15% as compared to the United States, which is like upwards of 90-95%, I'm sure, amongst all oropharyngeal cancers. And even in the 10-15% positive that we see, they are tobacco chewers, and we don't really know the implication of chewable tobacco. The most of the data is from smoking, which comes with pack years. If you look at Kianang's classification, so it is difficult for us to truly identify the patients who will do really well with any of the strategies even when we find the rare P16 positive oropharyngeal cancers. Now, coming to immunotherapy, as you know, immunotherapy, one of the major questions for us, at least, is the accessibility and the cost implications. We have developed our own strategy. It was presented in the one of the ASCO meetings 3 years ago, where we are doing low dose immunotherapy at a flat dose of 20 or 40 milligram instead of the usual doses 3 milligram per meter square or 480 milligram nivolumab every 4 weekly, or 240 milligram every 2 weekly. So we have developed that as an alternative, at least in the palliative setting. We are testing that those low dose regimes in sometimes now in the new adjuvant setting also, when they're clubbed with the standard chemotherapy. We are giving 20 or 40 milligram flat doses of nivolumab in the CPS score positive patients. So that is been really till now has been our go-to strategy. Particularly for oropharyngeal P16 positive patients, since our numbers are so low, we are not really pursuing them. So we are largely restricting this low dose neoadjuvant chemoimmuno strategy for the advanced oral cancers.
Thank you. Dr. Dad, HPV positive tumors, as has been indicated, a bigger issue in the United States. And how does that impact your perspective on therapy?
So thanks Anil, we were hoping for the latest NRG trial that was presented at last year's ASTRO, the HN005, where it was aimed at looking at HPV positive oropharynx cancer and comparing various de-escalation strategies, including dose to 60 as opposed to 70 gray, and the use of cetuximab as opposed to cisplatin. And even though there's been a lot of promise, this phase 3 randomized trial still shows that the standard of care that we've had for the last several decades remains the current standard. So despite HPV positivity for oropharynx cancer, we still aim to deliver 70 gray of radiation in the definitive setting concurrent with cisplatin. Then for oral cavity, I completely agree that it's not been shown yet. It's a subject of study on the implication of HPV on oral cavity cancer, but there isn't really an impact that it has. And in the adjuvant setting for post-op oral cavity, I think that's subject of study trial. It's not being done off trial at Columbia. And we mainly use immunotherapy for recurrent metastatic. And I think there's very strong data on that.
Dr. Dwan, you know, as we know in the literature, and perhaps it's even more in India, either the metachronous or synchronous association of head and neck cancer with esophageal squamous cell cancer. Do you see that? And if so, do you screen patients if they're able to be screened for esophageal squamous cell cancer?
Yes, we see metachronous cancers to the tune of 10%. One of the thesis of our one of the postgraduates was on double malignancies in head and neck cancer. So we found about 10%. Although literature does talk of 13% metachronous or synchronous double primaries in head and neck. If you allow me, can I add something on HPV?
Please do.
There was one postgraduate student of mine, maybe 12 years or even more back. He was doing the research work on HPV, P16 positivity in oral and oropharyngeal cancers. And we found that only 6% of the oral cancers were HPV positive. And oropharyngeal in India actually varies from 18 to 32%. Northern part of India, we have 18%. In southern part, it is 32%. And secondly, I will disagree with Dr. Nair, who says that radiation is the answer for all oropharyngeal cancers. I will prefer robotic surgery for a young patient with good mouth opening, early oropharyngeal cancer. I think the treatment nowadays should be robotic surgery rather than radiation.
Thank you. Dr. Sinha and Dr. Dad, could you clarify the role now or in the future for proton beam therapy? I realize it depends upon stage and several other factors, but sort of how you approach thinking about that. First, Dr. Sinha, and then Dr. Dad.
Yeah. So in India, currently, we have 2 functioning proton center, one of them in the private setup that is in Apollo Chennai, and we are the only the public proton therapy center as of now functioning in India. So as of now for head and neck cancers, our case selection is largely restricted to skull-based tumors, nasopharyngeal cancers, and re-irradiation, and that too very specific re-irradiation, because we are cognizant of the appropriate utility of proton therapy centers. There are other proton therapy, there are other tumors like pediatric cancers and brain tumors which also require slots. So we have limited slots. So we have kind of restricted ourselves to these things only. We routinely do not treat post-op oral cavity or even oropharyngeal cancers with proton therapy. However, we are aware that the trial which was presented again last year in Astro from MD Anderson Group, it was a multicentric trial which showed that perhaps proton therapy may be beneficial in general for head and neck cancer patients. Of course, we await the final publication of that. There is also the Torpedo trial going on in UK, and even the Danish trial, the Hanka trial also has completed approval to my knowledge, and all of them have some positive results to show. So I think we will hear more about proton therapy in future, particularly as the survivorship improves. We will be looking more towards improving late toxicities, quality of life issues, and perhaps I think proton has a bigger role to play in routine management of head and neck cancers beyond what we traditionally teach now, so that they are restricted to skull-based tumors.
Thank you, Dr. Dad.
Yes, so I think I treated with protons when I was in Maryland for a while, 10 years or so, and for a younger patient, which we see a lot of these HPV positive definitive cases in younger patients, we try to limit the integral dose, and using protons can make sense to help do that, where you can see late toxicity like second cancer, which we worry about. And also the big concern, I think, is in late toxicity and the benefit you can achieve with proton therapy. But in current state, we reserve it exactly as Dr. Sinha has commented. For tumors encroaching the skull base, we would consider it for locally advanced nasopharynx cancer. We don't think of it so much in a traditional post-op oral cavity, but if you're going to be doing a post-op ipsilateral situation where we're just treating one side of the neck, it would make potentially more sense to have less spillage across the other side and impacting the pharyngeal constrictors. So like there are certain, it's not a slam dunk for all head and neck cancer, but there are select cases where the modality does make a lot of sense. And then retreatment again is really important. Then Anil, one more, I wanted to address Dr. Dwan's question regarding how TORS, robotic surgery, should be considered. And I think you are speaking, I think it's current, where the current state is. At Columbia, we have the same back and forth discussions with our surgeons on the optimal modality to address an early stage oropharynx cancer, where if robotics, which more than half of the time margins can be an issue or function can be impacted, that then involves potentially trimodality, and we worry about morbidity of trimodality therapy. But if there's confidence and in the disease factors as seen on imaging and on exam, that margins can be clearly achieved and that there's a low burden of gross disease, then I agree that surgery followed by radiation is also a reasonable approach as opposed to definitive chemo-RT.
There's a question in the chat about from Dr. Patel, who's a wonderful radiation oncology resident under Dr. Dad at Columbia. And that we obviously know the relationship or correlation of betel nut with oral cavity cancer. Does that extend also to other sites in head and neck cancer? Dr. Nair, do you want to try answering that first, and then Dr. Sinha and Dr. Dwan?
Can you repeat?
So,
can you just repeat? Sorry.
Yeah, the correlation of betel nut.
Okay.
We obviously know with oral cavity cancer, but does that correlation extend to other sites in head and neck cancer?
Yeah. So I have published one study in Indian Journal of Cancer a couple of years ago, where we looked for the incidence of habits correlating with the different incidence of cancers. And we noticed that in chewers, the commonest site is the oral buccal mucosa cancer, followed by oropharynx, and then mostly the hypopharyngeal cancer. So chewers, you have commonly see buccal mucosa and then hypopharyngeal cancers. And when smokers, we commonly see the laryngeal cancer followed by the oropharyngeal cancers. So it's maybe I was thinking, which is because the impact of the smoke which is more on the larynx and then hypopharynx. And when in no habits, if there are no habits, the common cancer we saw was the tongue cancers, oral tongue cancer.
Interesting.
So this is what I have seen. So yeah, so it was published in Indian Journal of Cancer.
Yeah.
Yes.
At a very personal level, I have 3 relatives in India, blood relatives, no risk factors, 0. I can vouch for that. Each of them with tongue cancer,
Yeah.
and one with
Cancer
recurrence
has
as well.
different etiological features other than
And one with recurrence as well that Dr. Dad helped me on. So I think we're at the end. Really want to thank all 4 speakers for wonderful presentations and answering our questions. We hope the audience that peaked at about 50, which by US standards is phenomenal. We hope the audience enjoyed it. And Pooja, I think we'll be transcribing this through an AI platform, so we'll get that out to all 4 speakers for their approval and then disseminate it. And thank you so much. We hope this is the launch of interactions and collaborations between the 3 amazing cancer centers. Thank you again.
Thank
Thanks a
you.
lot. Thanks a
Thank
lot.
you.